A very good evening. It's an absolute pleasure. It's a privilege to have all of you delegates present today for our ATORFIT CV Journal Club. Now, this is our third such journal club in the same series of ATORFIT CV Journal Club. And while we have this meeting under the guidance of our known experts, Dr. Anil Dhal from Delhi, Dr. Sarita Rao from Indore, and Dr. Dilip Kumar from Kolkata. Now, Dr. Dhal is in the middle of something personal, so he is trying to fix this and he may be able to join us. But while we have the other two experts very much present in the meeting. Now, as stated earlier, in this journal club, our mode at whatever new high impact intervention, identify interesting articles with the guide. And these interesting articles are looked at in slightly greater detail. Now, today's meeting, we are looking at one article each from the circulation, the interventional aspect of circulation journal, and also the interventional JACC, that is JACC journal. Now, the article from circulation, which we are looking at today, states and clinical patients with chronic kidney disease undergoing Impella-supported high-risk percutaneous coronary intervention. These are insights from the CVAD Protect 3 study, after which we will have a discussion with our audience by the second from JACC, as I stated, is titled as Predictors and Outcomes of Paravalvular Regurgitation after TAVR in severe type 1 bicuspid aortic valves. So as stated, we started with the first article. Now, this is from the Circulation Journal. And as I stated earlier, that's the title. We are looking at the angiographic characteristics in patients with Impella-supported high-risk PCI. Now, CVD patients are known. If you look, CVD and CKD can manifest as a wide range of manifestations: urine, atrial fibrillation, and myocardial ischemia, amongst others. While the mechanism which underlies this pathogenesis of developing these CVD manifestations, CKD, includes a wide range of reasons or mechanisms like calcification, inflammation, thrombosis, oxidative stress, and fibrosis. Now, set with that background, we need to optimize the outcomes of PCI and chronic kidney disease, which will be determined by various things like reducing the contrast, proper hydration of the patient, drug-eluting stents, radial access, and so on and so forth. So the background of this study was there is no data existing about patients with advanced CKD who are undergoing Impella-supported high-risk PCI. While the changes in cardiovascular disease risk during CKD progression can be stated on this image. From left to right, we're going from no CKD to the last stage, that is stage 5 or dialysis-dependent CKD. And the y-axis is looking at the risk increasing both the sides. So that includes the various manifestations like atherosclerotic CVD event, CAD, ischemic stroke, and PAD, which as the CKD stages progress, these manifestations would worsen. The risk of non-atherosclerotic cardiovascular disease, LVH, arrhythmias would all increase with the higher stages of kidney disease. And the risk of fatality after CVD event would also be higher. Now, chronic kidney disease and coronary artery disease, as the GFR declines below 60 to 75 ml per minute per meter square, the probability of developing CAD would increase linearly, as is shown on the image on the right. Now, patients with CKD stages of stage 3A to stage 4 have approximately double and triple the CVD mortality risk, respectively, relative to patients without CKD. Now, proportion of patients undergoing invasive management declined with worsening kidney function. So on the left, we can see this is patients with no CKD, where the invasive management shown by the blue bar is the highest. Now, this invasive in color bar on the extreme patients or hemodialysis. So effectively, what we're trying to say is the frequency of invasive management, revascularization, PCI, and CABG shown with the other color bars among patients presenting with AMI by stage of CKD. So as the CKD is progressing or as the CKD is worsening, effectively, the proportion of patients undergoing invasive management is also declining. Now, findings from the PROTECT 2 and PROTECT 3 study. Now, patients supported with Impella 2.5 had a strong trend towards reduced major adverse events at 90 days compared with those who were supported with an intra-aortic balloon pump. Now, the PROTECT 2 study is a prospective randomized clinical trial of hemodynamic support with Impella 2.5 versus an intra-aortic balloon pump in HR-PCI or high-risk PCI. Now, after the Drug and Safety Monitoring Board stopped the trial for futility, the results were analyzed for 448 patients. And major adverse events were compared between the intra-aortic balloon pump group and the Impella 2.5 group. While the p-values do not look significant, the difference in the intention to treat population at 30 days and 90 days respectively between the two groups is what is depicted here. Now, conclusion is Impella 2.5 fails to reduce 30-day major adverse events compared in high-risk PCI. Analysis has favored the 90 days. Now, the PROTECT 3 outcomes compared to the PROTECT 2 are shown over here, where the comparison is shown in PROTECT 3 with Impella. So the objective of coming back to our analysis of the study was to evaluate the angiographic characteristics and clinical outcomes in patients with CKD who received Impella-supported high-risk PCI as part of the catheter-based ventricular assist device PROTECT 3 study. Now, what is known? The background is what is known. It is known that patients with CKD exhibit a greater burden of coronary artery disease and more calcified atherosclerotic plaques. Impella is increasingly utilized in PCIs to provide hemodynamic support. There is no large data about the angiographic characteristics and outcomes of patients with CKD undergoing percutaneous coronary intervention support with Impella. So the study was about 1,200 were assessed. Now, from have been excluded because of investment. So, effective patients were stratified baseline EGFRs. EGFR of more than or equal to 60 of 586 patients, EGFR of more than 45 to less than 60, which consisted of an N value of 190 patients, with EGFR more than or equal to 30 and less than 45 with an N value of 105, and with the last stage, that is EGFR of less than 30 or on dialysis, where the N value is stated as 171. So the study endpoint, the primary endpoint was a 90-day MACCE, which consisted of all-cause death, myocardial infarction, stroke or TIA, and any repeat revascularization. The secondary endpoints included individual components of the 90-day primary endpoint, one coronary angiographic characteristics and immediate PCI-related complications, and in-hospital adverse events. So the study findings showed that patients who had a lower EGFR, that is all groups with EGFR of less than 60, were more frequently females, and they had a higher prevalence of hypertension, diabetes, anemia, and peripheral artery disease. Patients with lower EGFR were more likely to have severe coronary calcifications and higher use of atherectomy. Overall, PCI complications were less frequent among patients with lower EGFR. The MACE at 90 days, that is major adverse cardiovascular events at 90 days, and one-year mortality was significantly higher among patients with EGFR of less than 30 ml per minute. The findings shown here again in the graph, interestingly, patients with an EGFR of less than 30 or on dialysis were more likely to experience MACCE, shown over here in the color red. So the color red on the graph on the right is shown as those patients who have an EGFR of less than 30. Their MACE, that is MACCE, is higher as compared to patients with GFR of more than 30 to less than 45, more than 45 to less than 60. shown in the other different colors, blue and green respectively. Patients with a GP or on dialysis were most likely to cause death at 90 days compared with patients with eGFR of more than 30 to less than 45, more than 45 to less than 60, and more than 60 per 1.73 meters square, respectively. So the take home is patients with advanced CKD and those on dialysis undergoing Impella supported high-risk PCI have more comorbidities, including anemia and PAD. Impella supported HR-PCI, that is high-risk PCI, is safe and associated with an overall low risk of PCI-related complications, advanced CKD and those on dialysis. Patients with GFR of less than 30 or on dialysis did have a higher risk of in-hospital mortality, MACE and cardiovascular deaths at 90 days, with all-cause mortality at 1 year being 40%. Now, before we proceed on to the next study, I would like to request the experts to start the panel discussion. Over to you, sir and ma'am.
Yeah, thank you, Deepak. And I think this study has highlighted very important points, some of the very important points. So to begin with, let me clarify about PROTECT 3, trial. So this was a single observational study. It was not a randomized controlled trial. So and the cohorts where the patient population where PROTECT 2 like patients were there included in PROTECT 3. So those patients who were having PROTECT 2 like characteristic, the result and observational result of PCI on Impella support were compared with the PROTECT 2 arm. So this particular subset of study, which we just discussed, CKD patients with GFR ranging from less than 25 to more than 65, 75, all across GFRs. And what was the outcome? So 2-3 very glaring points were there. One is we all know that lower GFR patients have low hemoglobin, they are anemic. Second, they have more chance of peripheral arterial disease. So if we have to put Impella, we need a good femoral artery to go, through that and insert the Impella. So we require a 12 French for Impella 2.5, a 14 French access for Impella CP. So in spite of your requirement of peripheral, good vasculature, the presence of anemia and PAD in this particular study did not show any kind of wrong signals as far as Impella insertion was concerned in these patients. And the result was, as good as what we see in patients with normal GFR. The PCI complications were also more or less okay. And there was not much of difference. Rather, PCI complications were more in normal GFR patients. So that is really something which I think Dr. Sarita can, highlight. How come PCI complications were, more in normal GFR patients rather than low GFR patients? And rest, everything was predictable. Rest, everything predictable means the Impella gave equal support in low GFR as well as more GFR patients. And finally, 40% of these patients died after 1 year. So low GFR patients had high mortality. So now I turn to Dr. Sarita about her view on this trial, how what kind of message this trial is giving to all of us, what is kind of extra takeaway from here, and how come patients who had a higher GFR had a more PCI complications, which we saw here. Is it an outlier or it's just a kind of observation which we got?
So, Dr. Dilip, this trial is very interesting.
Yeah.
So, when we talk about CKD patients, and what they found that these CKD patients were generally in this trial, what they observed that these patients were the lower GFR patients, they were more likely to be female, they were more likely to have anemia, they were more likely to have peripheral arterial disease, they were more likely to be hypertensive, more likely to be diabetic, and also more likely to have extensive coronary calcification. And they also ended up having more amount of atherectomy device use. So this was the category of patients now we were dealing with. Now, why CKD is such an important thing for all the interventionists, and it is the Achilles heel, because when you're doing PCI in a patient with CKD, there's always a question, because PCI, you will require contrast load, right? And however much you try to reduce that contrast load, there's always an option that there will be some contrast used during the procedure, which is even more deleterious for the renal functions. At the same time, now perfusing the kidney during the procedure is also very important. Now, what is the problem? These high-risk PCI patients, whenever they're doing high-risk PCI patients, left main, triple vessel disease, extensive disease, poor LV function, diabetic, hypertensive, and this entire category of patient, if during the procedure, at any time, if the patient's hemodynamics drops, the renal perfusion is adversely affected and this patient will crash on the table. That is where the concept of using the Impella in such patients was very important, because whatever, it tides you over the procedure. And when you are being tided over the procedure with an Impella pump, which is maintaining perfusion to the kidneys, irrespective of how your procedure is going, your kidney is never going to be adversely affected. Which is why if you see that the complication on table was not worse for these patients. These patients did well on table. They were barely, the complication rate was not higher for these patients, in spite of the fact that they had more extensive disease, more calcification, more atherectomy being used, but on-table complication was not higher because the Impella was there in place. Also, Dr. Dilip said a very important point right at the beginning. This is not randomized. This category of patients cannot be randomized. It's important to know that these are sick patients. You can't randomize these patients. It will always be an observational, and we see how these patients are doing in this category of patients. So, but again, at what we observed again at 90 days. And if you look at the difference in the event rate, if you look at the differences, it's not statistically significant, but you do look at the difference in the numbers. But a very interesting observation, which you said that this group of patients actually had less complication. How do you explain that? I'm not...
So I think
was it only because of the backup of the Impella, which was providing the hemodynamic support to the heart? Was it just the difference that these patients had an Impella, which was giving them the adequate cardiac output, perfusing the kidneys appropriately? Or was it something else?
Yeah, I think the writers of the article also couldn't find any logical answer for that. And probably those patients who have a low GFR, the operator was more meticulous and using lesser contrast and kind of being more adjunctive devices, and they were more protective, and an Impella was already there to protect the kidneys. And we from Protect 2, we have this knowledge that the benefit of Impella was primarily driven by the lesser kidney dysfunction and avoidance of dialysis. So at 90 days, Protect 2, at 30 days, there was no much significant difference, but at 90 days, these patients on Impella had a better outcome, and that was primarily and heavily driven by avoidance of dialysis and better kidney outcomes.
So the very fact that when we have the Impella on board, there's going to be no sudden hypoperfusion of the kidneys. There's going to be no sudden drop in blood pressures. At all times, a certain amount of cardiac output is always maintained. So the dramatic changes which we have when we are doing a procedure in these changes, sudden hypotension, no reflow, patient having CPR on the table, all those things which happen, especially when we use atherectomy devices, many a time there's slow flow, there's transient bradycardia, all these things which have a very adverse effect on an already compromised kidney. We have to understand that these patients don't have normal kidneys. They have poor eGFR, they're compromised kidneys, and any sudden hypoperfusion, any sudden hypotension can absolutely land these patients in an AKI. So I think the whole idea that the blood pressure was maintained throughout the procedure, perfusion was maintained, no dramatic changes in hemodynamics, made these patients, very sick patients, sustain the procedure very well. which is
I think,
why,
yeah.
and in such sick patients, you don't see the responses immediately, which is why it took 90 days for that graph to start moving away from each other.
So I think this study reestablishes the kind of kidney benefits which comes out from Impella, and that is, I think, solely and primarily driving the the benefits. The kidney perfusion remains there, and the patient sustain that kind of period of stress while we do intervention, and we can complete the procedure well. We can do better revascularization. You see here in Protect 3, the syntax score dropped from 28 to 6. So there was such good kind of revascularization. In Protect 2, it was something like 30 syntax coming down to only 15 at the end of the procedure. So with better PCI techniques and more faith on this Impella, in Protect 3, the operators were more aggressive. They were attaining more and more better syntax score, after the procedure, more complete revascularization. Atherectomy devices were used in 37% of the cases as compared to 14% which was used in same Protect 2 cohort. So we got an insight that Impella is really working, and also a few word about Impella in cardiogenic shock. We have very good news from Danger Shock trial, which was a positive trial which was stopped prematurely, and also a Restore 4 trial was also stopped prematurely because there was a benefit, great significant benefit which is seen in Danger Shock trial. So Impella is really coming up in a big way, and maybe as Dr. Sarita just told, that these are very sick patients, especially cardiogenic shock patients. That's why we don't get these randomized controlled trials. And protected patients, like protected PCI, is one subgroup of patients where we can plan the strategy, we can utilize this very useful device and complete the procedure well. So what about vascular complications, Dr. Sarita? I think with vascular complications coming down, yeah. So what's your take on vascular complications in these patients?
So I think when we talk about vascular complications, these are large French devices. But having said that, we have got very good closure devices. Also, it's very important that you plan your procedure. We know that these the size of the arteries have to be evaluated before you start the procedure. We have to do an ultrasound of the groin vessels and see how good they are and whether they'll accept the Impella. And in most of the cases, all the cases that we've had good access. No vascular complications have been occurred because you have such good closure devices, one. Second, especially when we are doing high-risk PCI, most of the time we use the Impella for on the table, and a couple of hours later, we wean the patient off and we remove it. It's for the cardiogenic shock patients that, the vascular complications are more important because for them, we keep it for a much longer period of time and we keep it in the ICU. So the cardiogenic shock patients remain on the Impella for a much longer time. And in them, then the question comes of bleeding, then the question comes of infection over there because it's an open site. But I think with the improvement in the closure devices, the vascular complications are coming down. Also, pre-procedural planning, appropriate ultrasound-guided access, looking at the size of the arteries before you insert the Impella, all of these things have really helped us in a great way. But yes, again, when you talk about CKD patients, and in this trial especially, more of the patients were female, and we know that females have smaller vessel sizes. We also know that these CKD patients had more peripheral arterial disease, and peripheral arterial disease, again, would give us problem in inserting the Impella from the peripheries. But having said that, they didn't really find an increase in the amount of major vascular complications in these patients. It can be dealt very well as of today. So I think, and when we talk about shock, so for high-risk PCI, all of us are using it, very well for high-risk PCI. And even in cardiogenic shock, it's very important that before, it goes way down in the shock staging, it's most important the earlier you insert it, the more benefit the patient has, the more chances you have of taking out the patient with the device if you can insert it earlier on before the vicious cycle sets in.
I think, yeah, touched upon a very important point. In Danger Shock trial, the alarm to institution of Impella was 15 to 30 minutes. So they were so prompt. And all these patients were given Impella within 24 hours of, cardiogenic shock. So none of these patients were more than 24 hours in shock.
But
So
that's very
early
important.
disseminate, yeah, that is very important. And
And
also,
also, at the same time, when you talk about, vascular complications, see, female patients, smaller vessel size, and more chances of vascular complications has always been said. But having said that, if these female patients were instituted the Impella early on, they actually had better results than the male patients. That was also seen.
Dr. Deepak, do we have any questions from audience?
Yes, one question which has appeared over here is what are the predictors of worsening kidney function in high-risk PCI, especially taken up on Impella? So that is one question which has come in here.
I think
Are
Dr.
there any?
Sarita alluded to, it, if we are using more of contrast, and if you are having more of a hemodynamic instability during the procedure, like more of even on Impella, if the patient is having more of a duration of uncoupling, so there is a like intrinsic heart is not working and Impella is working, and an incomplete revascularization. So I can think of only these three factors which can tell you that these patients can have more adverse kidney outcomes and decline in GFR.
So basically, when these patients and that we are always monitoring the urine output, we are always monitoring the lactate levels. So if if your patient is going into adverse hemodynamics, your urine output is going to start dropping, your lactate levels are going to go up. And the use of contrast today in CKD patients, what we are doing is more of no contrast or ultra low contrast procedures. And the use of imaging, especially of the IVUS, has really helped us in a very major way. And sometimes even of a saline OCT, because many of the centers don't have both of the imaging modalities. So even if they have an OCT, they can do a saline OCT. Or if you have IVUS, that's the best. You require no contrast, and you can do an absolutely no contrast by the skeletonization technique. So these things really help in cutting down the risk to the renal. The most important thing is monitoring the hemodynamics. If that doesn't have any dramatic changes, then your renal perfusion is not going to go down, then you're not going to have an adverse AKI kind of a situation.
Okay.
So after that great insightful discussion on the first topic or the first article, I would like to take you audience to the second topic as stated earlier. This is from the JACC journal, the JACC Intervention. And while the title is The Incidence, Predictors and Outcomes of Paravalvular Regurgitation after TAVR, that is PVR after TAVR in Sievers type 1 bicuspid aortic valves. Now, TAVR in BAV stenosis, that is bicuspid aortic valve stenosis, is technically challenging and it is burdened by an increased risk of paravalvular regurgitation or PVR. Now, pivotal RCTs comparing TAVR with surgical aortic valve replacement excluded patients with bicuspid aortic valve stenosis because of the perceived anatomic challenges for TAVR, which included a large elliptical annulus, fibrotic or calcified RAF, severe calcification involving the leaflets, the annulus, and/or the left ventricular outflow tract. Now, the ad hoc study, that is characteristics, sizing, and outcomes of stenotic RAF type bicuspid aortic valves treated with transcatheter device implantation, was an observational, retrospective, international multi-center registry, which was designed to describe the phenotypical characteristics of severe Sievers type 1 bicuspid aortic valve stenosis undergoing TAVR and to assess the safety and efficacy of contemporary generation THVs, that is transcatheter heart valves. Now, the inclusion and exclusion criteria of the study consisted of the following. While for inclusion, it was patients with the age of more than or equal to 18 years with severe aortic valve stenosis, with type 1 bicuspid aortic valve pattern based on Sievers classification, availability of pre-procedural multi-slice computed tomography, that is MSCT. The exclusion criteria consisted of Sievers type 0 or type 2 BAVs, valve-in-valve procedures, pure aortic regurgitation, and the non-transfemoral approach. Now, this is the baseline demography, which is shown over here for the study. consisting of age, BMI, sex, other confounding factors, comorbidities, etc. Now, consecutive patients between the Jan of 2016 and October of 2023 with severe type 1 BAV stenosis, as stated earlier, undergoing TAVR with current generation transcatheter heart valves in 24 international centers were enrolled. The PVR was graded as none or trace, mild, moderate, and severe according to echocardiographic criteria. The endpoint of the major adverse events was defined as a composite of all-cause death, stroke, or hospitalization for heart failure, was assessed at the last available follow-up. A total of 946 patients were enrolled in this time period. The PVR occurred in 44% of these patients, that is 423 patients, with mild, moderate, and severe consisting or happening in 387, that is 40.9%, 32, that is 3.4%, and 4 patients, that is 0.4%. That is 4 patients got severe, 32 patients had moderate, and 387 patients had mild PVR. The independent predictors of moderate or severe PVR were a larger virtual rough ring perimeter, severe annular or left ventricular outflow tract calcification, a self-expanding valve, intentional supra-annular THV positioning. At a median follow-up of 1.3 years, moderate or severe PVR was associated with an increased risk of major adverse events. Now, the same thing is shown over here in the image. Now, in the image, it's depicting paravalvular regurgitation after TAVR in patients with severe type 1 BAV stenosis. The N value of 946. These were consecutive patients, as I stated earlier. All these patients had severe type 1 BAV stenosis. They were undergoing TAVR 2016. The gist, which is patients with severe stenosis with current generation trans PVR is common, mild, severe PVR, 4% of cases, and was associated with increased risk of MAE, that is major adverse events during follow-up. So the conclusion after TAVR with current generation THVs in severe type 1 moderate occurred in only and was associated with major adverse follow-up, median follow-up of 1 larger VRR perimeter classification, CTHVs, and intentional supra-annular THV positioning were independent predictors of the moderate or severe PVR. However, the study does call out its limitations. These are the first one being expected suffer selection and reporting an inherent. Secondly, there was lack for imaging analysis, which raises concerns about potential inter-observer variability and inconsistency in MSCT and echocardiographic analysis. Sample contribution from the various centers was dissimilar, thus limiting the generalizability of the results. The RAF is a 3-dimensional structure, and some inherent MSCT measurements, like RAF, should be intended as surrogates because of their 2-dimensional natures. The high age of the included population limits the general younger population with severe type 2. The following may not effectively capture the long-term clinical impact AVR, PVR, potential detrimental if PVR may have been missed at a longer follow-up. Now I will again experts with the discussion on as we can take up the audience questions. Over to our 2 experts for discussion on this.
Yeah, I think again, very interesting. So all of the initial TAVR studies, they excluded bicuspid aortic valve patients. And the initial registry data from valvular therapeutics, TVT registry data with first generation TAVR valves, they showed that the complication rates were higher in bicuspid aortic valves. But this is very reassuring. Further data has emerged that with the current generation TAVR valves, the results are as good as what we see in tricuspid aortic valves. But definitely there is a trade-off between annular injury and PVL, which remains there. So we know that bicuspid aortic valves have a more of annular calcification, LVOT calcification, more of leaflet calcification. They have high chances of conduction blocks. They have high chance of annular injury because of calcium protruding and rupturing the aorta, annulus. And also there is, because it is highly calcified, and the hinge point sometimes can be supraannular, not the annulus. And all these factors lead to PVLs. So the 3-4 predictors which they have come across, which have significantly shown to giving rise to more of PVLs are: first is LVOT and annular calcium, second was virtual referring, and third was self-expanding valves. And so these were the basically 3 factors. And fourth was bavard tapering type of aortic valve and the LVOT. So where we look at more of supraannular dimensions in account in choosing the valve rather than the annular. So, but it's very reassuring that amongst the self-expanding valves also, they showed that accurate neo and the navitor was not contributing to the difference. Like with accurate neo and navitor, the results were as good as what we see with balloon expandable valves. So here I think we can little bit elaborate on that, elaborate on this particular point. They showed difference with the Evolute R and Evolute Pro designs, where I think these accurate neo and navitor, they have extra sealing cuffs, and there is a extra sealing skirt that gives rise to lesser of PVL, but they have found it more in self-expanding platforms, especially Evolute. So I think Dr. Sarita can elaborate about this study, the significance which it gives to us, and what are the takeaways, like what extra we have got from this trial.
So I think this study actually deals with a very challenging subset, and that is the bicuspid aortic valve. And that's significant amount of patients do come to us with this problem. Now, earlier, we used to be very worried when we were implanting in bicuspid and with the higher risk of complications, because the anatomy was such that we didn't have a circular area to implant it in. So the problem that always arose was when we implanted this valve, it wouldn't fit in so well. So we would have paravalvular leak. Now, the problem with paravalvular leak, this is not like a chronic AR. When you see a mild AR or a moderate AR, you know the patient tolerates it very well. But with this is a hypertrophied, stiffened ventricle. And when they developed a paravalvular leak, they didn't tolerate it at well. So what did this paravalvular leak it led to? It led to increased hospitalization, increased heart failure. And many a times these patients would require something else, and sometimes even a redo procedure. And the other options available was that, because of the ellipticity of the outflow, so a lot of people thought that, okay, let's post-dilate this to reduce the paravalvular leak. But then that again in this subset is very difficult, because when you post-dilate these patients, there's high risk of a rupture over there. Also, at that same time, there's also a high risk of embolization, because these are very highly calcified outflow tracts and annular calcification. So there was risk of rupture, and then there was risk of embolization when you post-dilated them. So what they actually found is that the self-expanding valves didn't do better. So it was the balloon expandable valves that did better in this, possibly because when you balloon expanded these valves, they ultimately ended up fitting better and reducing the paravalvular leak. But at the same time, what they found that certain valve designs, for example, the Sapien 3, if you look at it, it has a sealing skirt. So that helps in reduction of paravalvular leak. So that's important. I've used Sapien 3, and that does really help in that. They also said that for the Lotus, but we haven't used Lotus as yet. Now, the other thing with this bicuspid aortic valve is because of the eccentricity with which it is there, when you place the valve, it doesn't move in the typical normal position. It tends to move anteriorly and posteriorly towards the node. So these patients end up with increased requirement of pacemakers, permanent pacemaker implantation following the procedure. So all of these things made the bicuspid a very challenging situation. But now when you see this study and you see the results in bicuspid aortic valves, yes, certain things did come out. Yes, if you had a large virtual Raphe ring diameter, these patients didn't do, they had more of paravalvular leak. Like Dr. Dilip said, we discussed about the fact that more annular, LV outflow, calcification, again, difficulty in the valve fitting, difficulty in the valve expanding over there. It led to worse outcomes. Self-expanding valves didn't do so well. And of course, if you had an intentional supraannular positioning of this transcatheter heart valve, again, that would lead to more paravalvular leak. But they ended up having a paravalvular leak of moderate and severe of about 4%, which was dealt with in different ways in different operators and in different labs. But the results overall are quite encouraging because now bicuspid can be dealt very well with all the huge variety of valves that we have, with the sealing skirts that we have. And the way that they've actually, and many a times, if you have a tubular outflow, which is tapering, instead of, measuring at the annulus, you would go 4 millimeter above and measure over there, and then you would probably have a better result. So a lot of ways have come to deal with this situation. And you do have a lot of pointers about which valve to use and how to use. Again, the Evolute R was improved upon, and the Evolute Pro, a lot of studies said that it would do better. But then there are studies in which we didn't have the improvements which we had looked for. So still a lot of work going on in this area, but the results are very encouraging.
So I think amongst the valves, the self-expanding platform gives more of PVL, but they protect you from annular injury.
Yes.
Balloon expandable valve gives you less of PVL, but it can cause annular injury. So this trade-off we need to understand. So a patient of bicuspid aortic valve, if the CT shows a very chunky calcium, especially in the LVOT and annulus, then maybe a self-expanding platform is good. But with a bicuspid aortic valve with calcium, even if it is more, it's restricted to leaflets and the cusp, not extended to LVOT, then probably balloon expandable can be a better option. So this is how we choose stent platforms in bicuspid aortic valve. But one or two more reassuring data from here was, in partner to a trial, it was shown that those patients who even had a mild PVL, they had a bad prognosis and bad long-term outcome. But this trial showed around 45% of patients had PVLs, and majority of them have mild PVLs. And these mild PVLs did not change the future outcome of this patient. They were as good as those patients who had no PVL, but only moderate to high PVL substrate of patients had a bad future outcome. So this was again a very important point. What is your inputs here on this aspect of this study, Dr. Sarita?
I agree that, mild is generally these patients ended up tolerating it better. And so I think it's the moderate and the severe where we really need to worry about it, because that's what these patients do not tolerate. And then we have to do something for the paravalvular leak. You either post-dilate it more, but then again at the risk of an annular rupture, or you would sometimes we put in a vascular plug over there to seal the situation. So a lot of things that we can do, but yes, moderate and severe is not very well tolerated in this group. And it's also important that the very important point that you made is the amount of calcification and the location of the calcification really helps you in deciding which kind of valve that you're going to go in for. And again, when you're going in for a balloon expandable, many a times what the operators do is that they they don't dilate it to that point. They remove a little bit of it, so they underdilate it so that it doesn't end up, in a rupture. So that's also one of the ways to look at it. But yes, I think looking at the anatomy of the valve, looking at the way the calcium is over there, helps you to decide which valve you're going to use in that situation.
Yeah. So usually in tricuspid valves, we oversize our balloon expandables to 5 to 10% and self-expanding to around 15 to 20%, maximum. But in cases of bicuspid aortic valve, we never go more than 5%, and we try to be 1:1 if the calcification is more, especially confined to the distribution is around LV, OT, and annular calcium. So these are really, really important points. And if we have questions, we can take them.
Yes, sir. So some of the questions have, of course, been taken up in the discussion. So one of the question is, do different access routes of TAVR affect the occurrence of PVR in this group of patients?
Access route doesn't have to do anything here, because this is the type of valve which we are using, which platform, like this balloon expandable or self-expanding, so which we discussed in detail. And so the routes doesn't change the PVL outcomes.
So the paravalvular leak totally depends on the anatomy of the aorta and of the aortic valve. Now, how you go, so there are different access routes, right? The most commonly used is the transfemoral, but you also have a subclavian access route, you have an axillary access route, sometimes you have a transapical, but ultimately, it's the anatomy at that local point which decides the paravalvular leak. So how you're going to get your valve over there has not been shown in any of the studies to have an influence on the paravalvular leak per se.
Sure. Ma'am, of course, this one was answered. How do different TAVR prosthetic valve types and sizes affect the incidence of PVR? I think this was already discussed.
Yes.
Size is very important, Dr. Deepak, here, because in bicuspid aortic valve, we try to be 1:1. And if we feel that if the calcium distribution is little conducive, then we can little bit go maximum 4 to 5%, never beyond that. But in normal tricuspid anatomy, we tend to go high, 10 to 15%, oversizing.
Yep.
Sure. So I guess the other questions are typically repetitions of what you already discussed. I would like to thank you profusely for another great academic session. This was, of course, a great update for, I'm sure, all the participating doctors.